in anesthesia get this lovely zone of the perioperative management, which is oftentimes kind of a black box outside of those that actually work there. Just as a brief overview for today, I'm going to go over a quick case report about how this whole thing started and how I got involved in deciding to talk about this, do a little background information, go over some things about the opioids that are of most interest to us in this topic for today, and how they actually play a role in how we make decisions about what we do. And then just the biggest thing really I want to emphasize for today is talking about how we as a collaborative group can make plans better for patients. And ultimately, I think the biggest thing is making sure that they have fewer cancellations as a result of what they're taking. And then ultimately, from the other end of it too, have maybe even a better outcome on the other end of their surgery. So today we'll just start out by talking about the patient that kind of brought this all to a head. I was a 28-year-old patient on buprenorphine, a decent dose. I can't remember off the top of my head, but they were there for a gender mastectomy at our ambulatory surgery center, which is Madison Surgery Center. Their use of Suboxone was not caught until late in the process, basically the morning of surgery or the night before. I wasn't my personal patient. But they had a long history of depression and opioid abuse, but had actually been doing fairly well on Suboxone for well over a year. At the date of surgery, a long discussion was held prior to with the surgeon informing them that the narcotic medication doses at our ambulatory surgery center likely would not cover as they typically do for these surgeries. And it was asked if we could do some sort of nerve block or local anesthetic to help with that pain so that they could continue with the surgery. The surgeon refused, which ended up the case being canceled, as the patient in an ambulatory center really can't be admitted without risk for other things that we'll kind of get to later here as we kind of talk about some of those aspects. And the process then became bigger and bigger, trying to find the right place for the patient and having that continued conversation back and forth with the surgeon about how to do this. Ultimately, the patient did get their surgery. Everything has gone, as far as I can tell, well, but certainly was more of a discussion beyond even that fact, because at the time that this all went down, the patient actually had even threatened self-harm, which led to more complications, which we can actually talk some about with Suboxone too, as just a reminder for those that don't remember exactly all the beautiful things that Suboxone can provide for these patients that have this struggle. So that's where we started. Just really brief background. It's kind of preaching to the choir here, I understand, but 2016, the data says 50 million adults struggled with chronic pain. 2018, they tell us that 2 million people in the United States had opioid use disorders. Opioids were prescribed to 80% of elective procedures. 6% of opioid naive patients were still taking them at 3 to 6 months. 27% of chronic opioid users did receive their original prescription following a surgery, most of those elective surgeries. And about 130 people died every day due to opioid overdose. I know those numbers are actually worse now than they used to be. This is obviously prior pandemic information, is the best I could find from the stuff that comes from our world of anesthesia. But it's a major, major thing. And we in the world of anesthesia, surgery, which unfortunately they're not here to talk about their end too for the post prescriptions. We are finished with them in our discharge phase from the surgery centers that we take care of them at, but certainly we all play a role in usually being the first one to crack the lid off the first opioid that these patients have. As a really brief background, the two that I'm interested in usually that come up in chart reviews that we go through, methadone, which is our oldest visitor to this anticipated how do we help these folks out, developed back in the 1930s. It's further back than I realized. I didn't remember it being that far back, but the mu receptors, NMDA receptors, they're the target there. But this was really a big push after World War II, because all the heroin that came into the US metropolitan areas, you saw a lot more increased illicit drug use. And then actually was a federal program to help with narcotic maintenance, which is an interesting thing to go through. That I only had run into previously in my early life, knowing that that was something that had a federal backing to it, which is an interesting thing to think that that went back that far. The biggest pieces that we always have to think about with that one, it has to be monitored more closely. It's got some higher potential for abuse. associated with the highest rate of accidental overdoses. In fact, contributing to one of 3 overdose deaths in 2009, which obviously they knew this kind of going into it, and people kept working. Thankfully, we got ourselves more, what would you, friendly medications to work with, things from the buprenorphine bin, if you will. The 1970s, that's when that showed up in our usable list. Currently exists as Suboxone, or most common version. That's what we see. Actually, I think of all the patients I've seen this year, it was methadone or Suboxone. Other formulations I really just haven't seen, and I'd love to have your perspective on that from your end today too. We know that's about 30 times as potent as morphine and has effective analgesia at very low receptor occupancy, so 5 to 10%, which kind of gives it its longer, likely gives it some of the longer acting aspects too. It doesn't really have to be bound as intensely to do its work. Sublingual doses of 16 milligrams, you're going to get somewhere between 79 to 95% of those receptors occupied. And if you go even higher than that, it really doesn't change a whole lot. You're going to have partial agonism at mu, antagonism at kappa and delta. There's less potential for abuse and the respiratory depression side effects compared to traditional opioids. The biggest thing that I will say at this point that we're going to talk about and why we get excited about these things is that because of that low dose and because of the long lasting aspects of this, really takes a lot of traditional opioid to overcome the effects of these medications when they're given, which, what does that leave us on the day of surgery? The effects of anesthesia, we can always talk about very briefly, to be reminded that we have both anesthesia and analgesia. I can help anybody forget what's going on, but they will still show me on a monitor that they have some sort of sympathetic response to pain, unless it's covered. So that's the analgesia portion. So I would tell you that for the most part, it's not 100% true, but for the most part, you can anesthetize anybody that's on these medications, just with sometimes a little bit higher dose. The difficulty actually comes with the analgesia. So getting somebody off to sleep, keeping them for pain-free type procedures, specifically things that come to mind, things along the lines of colonoscopies, especially if you're not using an opioid medication for your part of your sedative. Other things along the lines of office-based procedures, those types of things where you're just getting somebody just a little bit off, not a problem. Really, we don't care about these medications. Where that comes up more is when things get a little bit more intense. Deeper surgeries, bigger surgeries. So if you think about the receptors that we're left with, if you take all of those opioid agonists over here, and eliminate those, we're left with certain other things that can be utilized. You've got your alpha-2 receptors, so that's our Precedex or clonidines. You've got some calcium channel type things, which pregabalins, gabapentins, benzos, plus minus, depending on what you read and how. You've got your NMDA receptors, so your ketamines, magnesium type things. The rest of it being that opioid component, if that's eliminated, that you're kind of looking at how things go. And then really the only other piece, and the reason I added 2 pictures here, is that the local anesthetic. So basically interrupting the actual communication on back to the brain. And how long we can make that last really depends on the argument of how long does a person have the ability to leave a catheter in a place before things become more of an infection risk, which from that perspective, really that's somewhere between 5 to 7 days. So with that, I will say just these are brief plugs. Awesome work by Dr. Hartman getting our preoperative assessment clinic up and alive in October. We are continually modifying our algorithm that kind of pre-screens all of our surgical patients. Part of the discussion today actually was desired by Dr. Hartman to see kind of what the appetite would be from your department end to adding something like Suboxone or methadone to that list of things that could be pre-screened. Obviously, for each of these patients, whoever's on call for anesthesia or the on-site medical directors can always be approached to make sure that we do some good planning. Otherwise, I will say if those two sites are not approached or not triggered, it's going to be the night before that these patients are first seen. As we've already discussed, and the reason I went through all that long list of things, which are probably just review for everyone here, you're really only going to have a very minimal amount of time to respond, which we don't have time to then say, please don't take it. So, perioperative management, there's three major questions which come up anytime these people get screened with those pre-screening opportunities. Where do they plan to have the surgery? Are they going to be at the hospital? Are they going to be in the outpatient portion of the hospital? Or are they going to be attempted at an ambulatory surgery center, which we can get into more details, which we will in a minute, but really it's a glorified dental office. How invasive is the surgery going to be? Sometimes more invasive surgeries are done in outpatient surgery centers or ambulatory surgery centers. In fact, CMS is pushing as much as they can to push more surgeries that direction. And then how does the patient actually respond to pain and surgery? A lot of these patients that I have had the opportunity to screen have had prior surgeries and they've actually done quite well. Having a footprint to follow in the snow, if you will, is a really nice way to be able to say, you know what, I know they're on methadone, but it looks like this is what they did last time. Shouldn't be an issue. They should be able to function anywhere. Um, Briefly, inpatient surgery, just from CMS perspective, anywhere where you're expecting to stay more than 24 hours. That means that we have the opportunity to have in-house anesthesia. They have in-house pain services, both acute and chronic. And any of that can be utilized by the intaking service. So whichever surgical service brings them in. It's a beautiful opportunity to utilize as much as possible of the resources anesthesia has to offer. From the outpatient surgery perspective here at UW, some of the other places I worked in the past in private practice settings, that outpatient surgery center was a little less access to us, but here, thankfully, still have the same opportunities to get a little bit of feedback if they end up staying the night. Again, you can put it in a consult to help with some of that kind of thing if it's not something that's thought about in advance. However, when you get down to the ambulatory surgery center level, you face potential penalties, CMS review for each admission, meaning that you really have to have your ducks in a row before you say, yes, this person will absolutely fly out of our surgery center and we shouldn't have any concern or worry about them getting home. With the other piece that's really important for us to talk about from the anesthetic perspective is the timing for selection and planning. Is this an elective surgery or is it an emergent surgery? Obviously, if it's emergent, we just go ahead and they're going to end up inpatient and they're going to end up getting access to all of the extra things that we have on board. We can use drips, we can use lines, catheters, everything that we need to do to get them the pain management. So from our perspective, really, if I see that on their list, all I do is just say, I'm going to turn it up and we'll figure it out. Makes it fairly simple. We'll kind of talk about some of the algorithms that have been written for that elsewhere in our discussion today. But then if they're elective surgery, that's really where we are targeting our best opportunity to help these patients improve their quality of experience, both from an outcomes perspective and the day of, and as well as, you know, from your perspective, not being frustrated by us sending something back to you or us being frustrated because something wasn't notified in advance. And ultimately, in the middle of those two discussions is the patient. And we're all here to take care of patients. You guys do a fabulous job, and it's a difficult job. And each stressor that we add to that, it just makes it worse for the patient and gives them a higher risk of having relapses and those sorts of events. Or as I even mentioned in our case that I had mentioned at the beginning, there was threat of suicidal ideation. So it can get quite extreme. So from that perspective, let's briefly dive into the elective surgery. There's a beautiful paper that was written in 2017. It was published in our biggest journal, which is anesthesiology. It's the last real big take, I would say, from the do it or not do it perspective for surgery when it comes to buprenorphine or other partial agonists. I'm just going to run through this because it is actually kind of an interesting flow chart. Anything preoperatively, their biggest thing that they stress over and over and over throughout this whole paper is talk, 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 talk between groups. whoever is prescribing and whoever is doing the surgery, as well as those of us that are taking care of them in that perioperative window from the anesthesia perspective. If we're expecting these things to be as straightforward as we kind of alluded to, things like colonoscopies, minor surgeries, things like wrist related things like carpal tunnels, hand surgeries, smaller surgeries, we oftentimes will have the patients continue their buprenorphine. We don't routinely send them home with opioid medication prescriptions because, as we kind of alluded to, it takes quite a bit of a prescription to get anything extra out of it. But we do lean heavily on other things like making sure regional blocks are done, that the surgeons use local anesthetics at the site of their incisions. Um, I'm a huge fan of Tylenol. In fact, I've been able to maintain IV Tylenol even if we can't get it down their mouth. We're one of the few hospitals I've worked at where they still let us touch that stuff. That's a long debate that can be had about its use and function, but NSAIDs for those that can take it, leaning heavily on that. I will tell you that most of the surgeries that I've had the opportunity to review, whether they can or can't go forward, they do very, very well with this. And actually, I do look in their chart days later, which I don't often do, but for these, I do just to make sure that we didn't choose incorrectly. And like I said, they tend to do quite well. Um, if they're off of their buprenorphine, then obviously then we make some dose adjustments. We make sure that there's some sort of taper back on. We make sure that the surgery team knows that they're off of their medication, and make sure that we have that discussion about what they intend to do when they go home before we dive in and start a process that they don't have the right prescription for afterwards, the right discussion afterwards. If it's going to be a bigger surgery, then we have to have that conversation, not so much about what we're going to do for anesthesia or how we're going to send them home, but where do we send them? And I would tell you that the patient that was at the beginning of our discussion, had they been in an outpatient setting where there was potential to watch them overnight, there's almost no like there's almost a 0% chance that they end up getting canceled, because all of us realize that with time we can make these things better for the patient, to give them a plan, gives us a chance. In that ambulatory setting, putting somebody in an ambulance, charging them $10,000, coming over, and then we have to write up a case where we transferred to the hospital, it makes for a lot of paperwork that could end up bothering more than just one patient. And I say bothering lightly. More, it puts a place under potential for review, which that's all rules, that's regulations, but it's part of why some of the decisions seem a bit abrupt with relation to that, and why a lot of these patients, if it's going to be moderate to severe pain, we just say not at the ambulatory center. We'll send you on to the outpatient or inpatient side where we expect to be able to manage and care for this. That's why if you look here, if they're still taking that buprenorphine and they show up and there's not a preparation for that, that's where that cancel surgery comes in. It's the least likely thing that anybody that we work with would be excited about or happy about. We don't, thankfully, here at UW get paid based on caseload. So we're making this hopefully from the right side of medical decision making. But there are places that, for those that have been elsewhere and maybe seen this, if you are paid on a case by case basis, somebody might push a case forward if they're paid to do it, where the right choice would be to cancel until they have the chance to set things up for them to succeed. Or you might go to the other end where someone might say, nah, let's just cancel it with even less consideration, mostly because they get to go home early. And here again, that's not something that actually happens. We're around until we're around, and then we go home when our shift is over. So thankfully, that isn't as much of an issue. And for most of these, it seems like logically that we are attempting to do the right thing medically. We can talk about, weaning as a group, because you guys know more about how to wean afterwards than we do, which is an admission of fault, I suppose, but it does actually leave something to be learned. And I think that that's important to remind people too, is that I will tell you that, knowing the group that I know here and the groups as I've worked with in the past, the after black box exists for us. We are very used to what we do during, but very few of us, unless you've worked in chronic pain, know exactly what you guys would do after. So that is oftentimes a barrier as well. Going on to the next piece to this paper that goes on to what we were talking about. So that's emergencies. This is where most of us actually feel a lot more comfortable. I know that seems odd, but a lot more comfortable caring for these patients because we have a chance to do things like if you look down here for these moderate to severe pain cases, you can use PCAs, you can use line-based things, you can use continuous catheters, you can use other medications like your Precedex that must be through an infusion, and some hospitals insist on them being in ICU level care to use that medication. Um, you can make sure that they're timing their Tylenol correctly, timing their NSAIDs correctly. You can start them on gabapentin with somebody to monitor so that their respiratory rate doesn't get affected when it's also added to the opioid bin. All of those things become much, much easier. And it also gives us a chance to consult onto your services, on other people that actually work with these patients on a regular basis so that there's actually some hope that when they go home, there's already a plan and we've got time to do that. But it's an interesting thing to look at from the perspective that, yes, it is a little different, but for us, it's probably where we're the most comfortable. These two papers are probably, if anybody is here and interested in kind of our perspective, if you will, from our specialty, this is where people will lean to when they look for information. This is the first two things that will come up. The one that a lot of these information in the last two tables come from is a paper out of our big journal, as I mentioned, and the other is one that was a review done recently where they actually did lean on that same paper to give some of that information. But if you're interested in reading a little bit from our perspective, because I know everybody's is a little bit different, I recommend them highly. Neither is very painfully long, but they're both very, very good.